Alrighty, good afternoon, everyone. Welcome and thank you for joining us again for our third difficult decision panel series today. We will be focusing on hospice and palliative care. I'm Neetu Sharma, Care Services Coordinator, and I'll be the moderator. Today, like I mentioned earlier, we're going to talk about hospice and palliative care. You will again get to learn about diverse perspectives from different industry professionals and also from caregivers who have directly used hospice and palliative care while taking care of their loved one. And now, without further ado, we will turn the time to Dr. McQuain. He is the medical director at Ferda Gordo Hospice and Palliative Care. He's going to talk to us about what hospice is, what is palliative care, the difference between both hospice and palliative care, and how it can be used as a resource for our ALS patients. If you have any questions that you would like to ask, you're more than welcome to submit them in the Q&A in the bottom, or you can also share them in the chat box that I'll be checking regularly throughout this session. Dr. McQuain, the floor is yours.
Great, thank you. It's nice to see everyone. If anyone has any questions as we're going along, feel free to either send a chat or a message and we can address those. I think it's best to always have a conversation rather than a lecture. So it's great to be here. I really appreciate you including me in on this topic. I think it's of extreme importance and it's a very misunderstood profession. I am medical director of a hospice and palliative medicine. I cannot tell you the number of times I have spoken to doctors, to caregivers, to patients, to family, and they say, oh, I'm not ready for palliative medicine yet, or, oh, you know, hospice, that kills people. Those are misconceptions that I hope to clear up a little bit today. You will probably leave today having more questions, and I think that's a good thing. So to start with, I want each of you to take a minute and think about your own health. How many of you have more than one medical condition or more than one medical doctor or provider, such as a nurse practitioner or physician assistant? How many of you take more than one medication? Despite going to and from various doctors, various clinics, taking all of these medications, even if it's two, my best guess is there are days when you do not feel your best, when you think that you could feel better than you do right now. So if we take that one step further, with everything that we know and everything we're experiencing, how many of you feel like you could use more support? Again, my guess is going to be most of us. That's common to life. It's even more common when we have serious illnesses or serious conditions. ALS happens to be one of those. So palliative care, I want to start first by talking about palliative, and then we'll finish by talking about hospice care. Palliative care really is that specialized medical care that's available to anybody who has a serious illness or condition. There are many conditions that qualify somebody to receive palliative medicine. If you're thinking, do I qualify? The answer would probably be yes, in that even if you are optimally treated, you still have concerns. Many of us still have shortness of breath or fatigue or anxiety, or need an extra layer of support from a physician provider to help address those concerns. The nice thing about palliative care is it's provided, it's available at any stage of illness. We like to get involved really at the time of diagnosis. We know if we're involved at the time of diagnosis and we walk that path with our patients, with the families, we know that the relationship that develops is beneficial to not only the patient and the family, but also to the clinician. That's where we really make our biggest impact. So at the time of diagnosis is when we encourage, and when national organizations do encourage, palliative medicine to get involved. The CDC really makes a point of commenting that palliative care is truly a medical specialty designed to provide symptom relief with the ultimate goal of improving quality of life, regardless of prognosis, which is a very scary term, and regardless of the specific diagnosis. So like I said, we commonly see ALS, we commonly see heart conditions, we commonly see lung conditions. Unfortunately, we do meet people when they're really in a crisis mode. Palliative medicine is here to help you avoid a crisis. At the time of diagnosis, we get involved. We address issues as they come up. We work closely with your primary care providers, with your neurology providers, and your other healthcare providers to make sure that there are no gaps being missed. Many of you may have heard of something called the Swiss cheese model. I like to think of palliative medicine as being at one end of that model. If you think about 5 pieces of cheese, the first one, shine a light through it. You put another one in front of that piece of cheese, the light still gets through, but less light gets through. If you have 3 or 4 pieces of that Swiss cheese, less and less light is going to get through. If you think about that light being a symptom, despite having those 3 or 4 layers up, we still have symptoms that keep us from feeling our best. My job and my team's job is to address those symptoms that you're having despite being involved with multiple providers. There are no specific criteria to involve palliative medicine. Again, it's really all about you. So along those lines, I get asked probably on a daily basis, well, what do you mean by that? What does palliative medicine offer? What do you actually do for us? So I like to think about 5 big topics. The first is just navigating complex medical decisions. We know that when we go into a physician's office, we are bombarded with information. That is very overwhelming. We know we retain only about 20 to 30% of that information. Palliative medicine can help walk through that information, help tease out what's important, what's relevant, and offer next steps and advice on those next steps. And we do that in the context of something called advanced care planning, which is another scary topic for many people. But advanced care planning is the process of having a conversation, talking through what I like to refer to as the what ifs. It's things that all of us will face as we get closer to the end of our lives. And it's important to talk about those issues early so that when we reach that point, we're able to know with a sound mind, we made decisions based on our preferences, based on our wishes, based on our own thought processes. Advanced care planning helps you avoid having others make decisions for you. It ensures that you stay in control of your health from beginning all the way through the end of our lives. So we do a lot of advanced care planning. The other difficult topic I get asked about is to offer a prognosis. Many people say, well, how much time do I have left? And I sort of chuckle at that because I'm not in charge of that. And this group is a perfect group to talk to about prognosis because ALS is very variable. I wish we could say, this is definitely what's going to happen. This is definitely how things are going to progress, but it doesn't work that way. So in offering prognosis, we are trained as palliative physicians to look at certain indicators, one of them being function, walking, talking, breathing, buttoning shirts, feeding ourselves, doing various things like that. We take that, we combine that with our other medical conditions, and we combine that with how rapidly our clinical situation has changed. So we have some conversations with your providers, neurology, with you, and we offer a more clear picture about prognosis, knowing that that changes, knowing that it's variable. We do a lot of symptom relief. ALS is one of those conditions that does have several what I call symptoms, whether that be things that we cause as medical professionals. Our medications all have side effects. You've probably experienced some of those. Our bodies change, whether that be physical, things such as pain, cramps, spasms, our skin changes. Sometimes people feel exhausted, maybe have secretions, trouble breathing, or feel anxiety, which makes them feel as though they're having shortness of breath. And a whole nother aspect that often goes overlooked is the psychosocial aspect, such as our roles have changed. When we are diagnosed with a serious condition, our role changes. We often become reliant on others to help us, whereas we probably previously were very independent. And then we also think about the spiritual health of the individual. Not religion, but spirituality is a very important component. So palliative medicine being available from diagnosis all the way through the end of our lives is the best use of palliative medicine. The gray area becomes transitioning palliative medicine or transitioning from palliative medicine into hospice care. Hospice care is 100% palliative medicine only. Palliative medicine is provided with the goal of increasing quality of life, decreasing distress. We really focus heavily on symptom burden, those symptoms that are persisting, that are getting worse. And with hospice, you have to acknowledge that going to and from various providers, going to and from neurology, going to and from cardiology, going in and out of the hospital is no longer offering a significant benefit. So we shift from that mindset of, I'm going to go in and fix this, treat that, see about this, get a picture here, get an x-ray there, do lab work. We shift from working up all of that medical stuff, that medical jargon that we all hear about, and we really focus on the person in front of us, how they look, how they feel, how they're talking, what their day-to-day life is. So we do with hospice, you give up the ability often to see some of those providers who have been with you for a number of years. With palliative medicine, it's the best of both in many ways, in that you have a palliative medicine specialist, and you then are able to continue seeing your other physician and other providers for various conditions that arise as you're going through life. What does hospice offer? It's not all about giving up. Hospice does offer a nurse, a registered nurse. It offers a social worker. It offers a chaplain. It offers a nurse's aide or a caregiver. And we also have physicians and nurse practitioners who work with our team. So although people sometimes feel like they're giving up this prior medical team, in reality, they're gaining a whole new group of professionals who are specifically trained to care for people who are at that phase of their life referred to often as the end of their life. That is a very gray term. In order to qualify for hospice, we do have to have a condition where two physician providers would confidently say, I wouldn't be surprised if life were to end within 6 months to a year. It does not mean that it will. Several people come on hospice, they remain on hospice for 6 months to well over a year. As long as we can demonstrate that you need that level of support, you need that level of care, and your body is continuing to weaken, and that's why we're involved, hospice can continue indefinitely. Hospice also does not mean that that's it. We have people who come on hospice and then go off hospice, whether that be their bodies really stabilize, their condition stabilizes. And then some people say, I really appreciate what you're doing for me, but hospice just isn't the right place for me. I still want to go back to my neurologist. I still want to go back to the hospital, and that's perfectly fine too. So hospice is not a place where people go to die. Hospice is truly a place, in my opinion, where people go to live fully, whatever period of time they have left to live. It's all about you. It's all about symptoms. It's all about quality of life. It has a very scary connotation. I wish we could overcome that. And I think through talks like this, we definitely can. I do want to reassure people that individuals who are involved with hospice earlier do better and actually live longer. So it's counterintuitive, but early involvement with hospice and early involvement with palliative care are the best option for anyone with a serious condition. And with that, I'll go ahead and take any questions, any thoughts, concerns, and do my best to answer.
Thank you so much, Dr. McLean, for your time and that very detailed, knowledgeable difference and explanation of both hospice and palliative care. We now open the floor for question and answers. You can submit them in the chat box or the Q&A. But before we do that, I do just want to briefly introduce you to our families that are joining us today. We will start with AJ as a quick intro.
Hello, AJ Kelleher. My husband had ALS. He lived with it for over 7 years. And one of the reasons I'm here is because he lived, I'm sure, an extra amount of time because we got on hospice. He was on hospice for over 2 years, actually, and he was with Jerry's company before he joined. And it's odd to say this, but even though we were on hospice and no one wants to be there, it was actually a very positive experience for us. So.
Thank you, AJ. Next, we'll go with Sally.
Hi, I'm Sally Hartman. My husband died of ALS in 2019. Unlike AJ, unfortunately, we didn't get in soon enough. So my husband was only in palliative care for probably 4 months and hospice for about 6 weeks. And I think if we'd had some of the information you shared with us today, I would have been better prepared to ask the right kind of questions and get better guidance. I think it's improving, and I highly recommend it for anyone who's in that situation.
Thank you, Sally. Next, we'll go with Tim.
I actually am an ALS patient, and our daughter-in-law is a physician assistant, and she suggested that we get into the palliative care as soon as possible. So about 3 months after my diagnosis, we got into palliative care, which meant last year that actually the nurse from our hospice group was the only person that I was seeing in person for a year. And that was very helpful to have someone who she came once every 2 weeks, and we talked in the in-between weeks. And it was very helpful to be able to do that. We got off of hospice for a time because I wanted to get a power wheelchair, and I couldn't do that through hospice. So I have been off hospice now for a couple of months, but I'm getting ready to go back on.
Thank you, Tim. And we will go with Vicki.
Hi, I'm Vicki. My husband Gary was diagnosed in 2012 with bulbar ALS, and he passed away in 2018. We went on hospice about 5 years in his diagnosis. He was, it might have been a little longer than that, because he was on hospice for about a year before he passed away. Our experience with hospice was a very positive experience. For me as a caregiver, it was really helpful just in knowing you had someone, the nurse that you could call 24/7 if you needed questions or if they needed to come. And when you're in that end of life stage, that critical time, there's a lot of scary things that happen. And just knowing that you have the people that you can call if you need them is priceless in itself. We were active with a chaplain also with the hospice, and my husband had an aide that come daily and took care of him, bathed him, and did those kinds of things, which was very helpful for me to have that. My husband was a veteran, so we had been on the VA before we went on hospice, and our experience with the VA was awesome, but their care not so awesome. And so the nursing care that he got, I never felt like I could ever leave him with the nurses, because he was on a vent and so many of them didn't know how to take care of a trach. So when we got on hospice, it was just nice knowing that the caregivers knew what they were doing and could help us with the medicine in all those end of life decisions. They were helpful in all of that.
Thank you, Vicki. I actually have lots of questions that just came in while you guys were introducing yourselves. So the first one is for the panelists and the caregivers. How was hospice used as a resource for the ALS patients?
I think for me, the biggest thing was, as Jerry mentioned, having one person to call when you had a question, an instant source to go to. And when there was conflicts and concerns about medication, you only had to ask one person to take a look at it and help make the best decision, and then direct you to who was the right medical person if you needed to get a person involved. So I think it was that quick access, good information, and then directing us to what we needed to do next.
I'll tag on to that. There were, because we were on it for a while, there were a lot of benefits for us. One, it had gotten too difficult for my husband to get out and get to clinic. So that made it slightly harder to get the attention of the neurologist for medications, what we might need, changing dosage, making sure we understood interactions. So as Sally said, we had, access to one person who could kind of help us coordinate all that, made it a lot easier to make any medication changes, to get the medications. We also had a CNA that I don't think we started with 5 days a week, but we definitely had someone for 5 days a week for quite a number of, quite a large amount of time. One, we had a wonderful CNA who we just really bonded with, actually 2 wonderful CNAs. So it was somebody from the company who was laying eyes on him every day. The nurse came every week. So then you had an even, more trained professional looking at him every week, kind of helping us gauge where things were, recommending things if we maybe hadn't thought of it. And just in general, there's no doubt in my mind, it improved his quality of life. Because again, if you get the right hospice company and the right people, it just kind of brightened our day actually when they came, and it was very comforting when there were things that were not going well. So
Thank you.
Yeah, I agree. We had the same aide that came in for the whole year and a half that we had hospice, and you just get to where you really are engaged. You get to know each other, and you're invested, and you feel like they're invested in you also. And I know with our aide and the nurse and even the chaplain, I knew that they were all coordinating my husband's care, and they all knew what was going on with him, and all of them talked together. They even told on me sometimes when I wasn't doing what I should do. And so it was just nice knowing that you had that team that were working with you, with your husband, and making life better.
For us, having contact with Grace every week was a huge benefit. It was because, as I say, that was the only person we saw in person for that period. And we were very comfortable with her. She was a great friend, really. And she helped us with a lot of different kinds of questions. She helped figure out things about medication. She was just someone who we knew was coming and we could talk to. That was a great benefit.
Thank you so much, everyone. We have more questions. This one is specifically insurance related. So who did you request these services from, and will insurance cover for them?
Yeah, so I think the first piece of that question, those are really good questions, and I see the others in the chat too. But those are really good questions. I would say you can request this from your physician, whether it be your neurologist or your primary care physician. One of those services can provide a referral, much like they would for a referral to a pulmonologist. The other piece is you can actually refer yourself. You can call up a local palliative medicine company and they can come out to see you. Or you can go to see them if they happen to have a clinic. Insurance, well, before I talk about insurance, the issue I sometimes run into is you really do have to be your biggest advocate, which is this community is truly a community, and you have people who can help you advocate for your needs. So when some of our clients call their primary care physician and say, oh, I want palliative care, their physician team will often say, you're not ready for palliative care. That's because of that misunderstanding between or among some people who perceive palliative care as being hospice care. They're two separate service lines. So palliative care is covered and paid for by most insurances. I haven't found one yet that does not cover it. The reason that is because we are a medical specialty, much like hematology, oncology, much like pulmonology or cardiology. We just happen to be another medical specialty. So you come to us, your insurance recognizes us as such, and they reimburse on whatever schedule or whatever fee they have established.
Thank you, Jerry. And here's another one in regards to palliative care and ALS clinic. How does palliative care and hospice differ from working with an ALS clinic?
Yeah, so that is an extremely good question. Actually, the National Hospice and Palliative Care Organization has a wonderful talk just about that. ALS clinics are essentially set up much the same way as our clinics are set up. So ALS clinics provide a multidisciplinary approach, meaning they have speech therapy, occupational therapy, physical therapy, nursing, physician's assistant, nurse practitioner, respiratory therapy. So you go to one place and you have multiple services. Some ALS clinics actually have a neurologist who has also completed a fellowship in palliative medicine. That's ideal. That ALS clinic offers what we call primary palliative medicine. That is that basic medical or basic palliative medicine that should be offered by all primary care physicians. Things such as you have excessive secretions. So we're going to put you on or recommend maybe atropine or maybe glycopyrrolate, maybe Sudafed, maybe Mucinex or guaifenesin. So that's the first line of defense. That's that primary level of palliative care. When those symptoms are persisting or maybe progressing, despite those initial attempts at control by your neurology team, that's when it's important to involve a palliative medicine specialist who can help with further recommendations and take it to the next level. We really do talk with the neurology teams on a weekly basis. After every patient visit or patient encounter, I have a conversation with the neurologist or one of his team members or her team members.
Thank you so much, Jerry.
Mm-hmm.
A few more questions. Both types of care were described as being about quality of life, hospice and palliative. Can you distinguish them a little bit?
Yep, great question. I think it's a tricky question in that all palliative care is not hospice. All hospice is palliative care. So palliative care is that quality of life focused care that really tries to decrease those symptoms, shortness of breath, pain, fatigue, secretions, constipation. Palliative care or medicine focuses to decrease those, to make those better, and thereby improve your quality of life. Hospice is that palliative care that is provided specifically at the end of your life. So when somebody is, to our best guess, and we've already heard examples from everyone that it's really difficult to say, what does that mean, end of life? But at the end of our life, when we're within that 6 month to a year time frame, that's called hospice. The difference technically is hospice is always palliative care. Palliative care is not always hospice. And with hospice, you do not go to and from the hospital, ideally. You do not get connected to some of those other specialty services, such as you may lose your pulmonologist, because we have physicians that are comfortable managing that phase of life. And Tim alluded to that a little bit too, to one of the questions. Palliative medicine allows you to do whatever. I'm just another consulting physician out here who is able to offer help for people. You can go to any other physician, any other provider. You can continue going to the clinic, getting your equipment needs met, getting all of the equipment you have and that would be available. With hospice, that's not available. So we encourage people prior to enrolling with hospice to really have a good conversation with their palliative team and with their neurology team to make sure that all of the assistive devices, all of the equipment that is going to be beneficial is really in place. I hope that helps. It is a gray area.
Yep, and thank you so much for giving that detailed answer, because we did have someone inquiring about eye gaze device, power wheelchair, and when is the appropriate time to have discussions regarding those. And I think, Timothy, if you could also share about your experience, because we do have someone asking us about, did you experience any issues getting equipment when enrolling into hospice?
We were already in palliative care when it became time to think about the power wheelchair. And then there was a back and forth about how it was going to be paid for. It could not be done through the hospice company because of insurance things. And so we stepped out of hospice at that point, the palliative care, so that it would be covered. I got the chair in this spring. I have not used it much because it's huge. It takes up an enormous amount of space, and it's not all that comfortable, to be honest with you. So I think there are maybe different kinds. I don't know about checking out the different systems, but in any event, you'll notice I'm in a wing back rather than in the power chair, because it's more comfortable. But that's a separate issue. The visits from the palliative care nurse were wonderful. We were very glad to have those, and we're sorry to not be getting them at this point, and we'll probably be signing back on sometime soon. There were a couple of other things, I think, that maybe we weren't able to get through the hospice system. I already have BiPAP machine and Astral that I use, and that I had that before I signed in to hospice, and so that has been covered as well. But I hope that answers the question.
Can I add a couple of thoughts to that, too? And jump in, Jerry, particularly if things have changed since I was in. Tim alluded to a lot of stuff. By the time Jeff got into hospice, we had the power wheelchair, the eye gaze, the BiPAP, a suction machine. So the large durable medical equipment, I don't think is going to be covered when you're in hospice. So with palliative, I'm not sure, but I was thinking that if you're in palliative, you could get that stuff and it would kind of fall under just regular insurance stuff. One of the other things that we did find, though, is that we already had a BiPAP machine, and being on hospice, the new masks and the new hosing and all that stuff is provided under hospice. One of the things we found, though, is it's typically going to come from whichever company the hospice company is contracted with. So it could potentially look a little bit different. I think you could probably get any mask you needed, but there's some, like our Yankar for the suction machine, we liked the one that had the hole in it that we could control whether or not it actually was suctioning, but that wasn't what was provided by our hospice. But that's a small enough thing that if you really want it, you go off and get it somewhere else. So just something to think about. Another distinction that I kind of want to think I think is true between hospice and palliative care is we were under Medicare, which with ALS, you get covered under Medicare sooner than other diseases. Hospice is covered at 100%. The palliative care, I'm assuming, correct me if I'm wrong, Jerry, is going to be covered, as you said, a specialty, where it's not necessarily 100%. So I think that's another distinction of if you've progressed far enough along and you've got the equipment that you need, and that's just something else to think about when you're weighing the decision of when to make that transition, if things are still the same.
Correct. And I think both of you are correct. I think the language gets a little bit confusing because we're so used to saying, oh, hospice and palliative medicine, but palliative medicine is separate from hospice. So palliative medicine is just another medical physician providing that service. And it is covered by a different piece of insurance than Medicare. Palliative medicine does not place any restrictions. I should say insurance doesn't place any restrictions on individuals who are involved with palliative medicine with regards to equipment, other physician visits, medications. There are no restrictions. It's just another physician service who is there to offer additional support, additional medications for those symptoms. It doesn't take anything away. Hospice is paid for from a different piece of that insurance. And with hospice, you are correct. Hospice doesn't have the ability to get those larger pieces of medical equipment, such as the Trilogy or the Astral or larger wheelchairs, those kind of things. So or the eye gaze devices. On palliative medicine, not an issue at all in any way, shape, or form. It's completely separate. On hospice, it is an issue when somebody, much like Tim was saying, when somebody is on hospice and something comes up, something changes where they maybe would benefit from a device, we talk to the neurologist. It's very easy to come off of hospice, get that extra piece of equipment, and then come back on hospice.
One thing I'd like to add to pick up on both of what you said, when we first started going to the clinic, the two terms were often interchanged. And I think there's been a lot more education. Yeah. But if you talk to people that aren't directly connected to an ALS clinic, you may get some conflicting information. So don't necessarily believe it. Go back and ask someone who really understands the current concepts of hospice and palliative. Because our pulmonologist kept saying, you have to have a trach if you have ALS. And this was 5 years ago, and he couldn't let go of that. So I really urge people with palliative, hospice, to make sure you're talking to someone that can really help you understand it.
Thank you, everyone. We have another question for the panelists. When did your family start hospice/palliative care service?
Well, we started it about 3 months after the diagnosis.
So for us, Jeff had ALS for over 7 years. And about 5 years in, I realized that I needed more help than I was getting. And I would have liked, and I really kind of wanted somebody there in the mornings to help me with getting him out of bed, whether it's a shower every day or every other day, or, teeth brushing or whatever it is, just somebody else, another set of hands, if nothing else. A lot of times I still assisted. So we kind of were getting to a point where we knew we needed to make some sort of decision about how we were going to get some extra help. And again, with where he was in the progression of the disease, kind of felt like while it was nice to go to clinic and just have people lay eyes on him, that there wasn't really more that was being offered to him in terms of, whether it's the equipment or, unfortunately at that point he was on a feeding tube, BiPAP, unable to speak using the eye gaze and basically unable to move. So there weren't a whole lot of things they were assessing anymore, except for his breathing, which is something that hospice was able to do for us as well. So we made the decision to go into hospice, and I'm going to be honest, I came up with a long list of interview questions, and I interviewed hospice companies because I found that, and I don't know if it's still true, but I found there's a difference between hospice companies that are for-profit, kind of a larger organization for-profit, and a smaller nonprofit organization. And you really need to decide which of those two is more important. The larger nonprofits had, it was easier to get medications mailed to the home. So if not having to go out to pick up the medications is most important to you, you might want a larger company that has that service. I wanted somebody that would give me a little bit more than the standard, you get 1 hour a day. And the company that we chose was like, we're going to give you the time you need, within reasonable limits, obviously. But there's more flexibility, I think, with the smaller companies in terms of the true in-home ability to provide support.
We started.
We went on, we went on a hospice after Gary had already had ALS for over 5 years. He lived for almost 7 years. So the hospice care, by the time we went on it, he pretty much couldn't do anything and had to have total care. And like AJ, I just needed the extra hands, the extra help, the relief to help with him in the mornings. And he also had lost a lot of weight. He went from 180 down to about 70 pounds. And so he had trouble with bed sores because of the weight loss. And so the hospice was there every day to monitor that, which was really important, and to give him the care that he needed for that. We hadn't dealt with that earlier. It wasn't until he started losing so much weight that became an issue. But when that became an issue, then we needed the daily care and the pain management that hospice was there to give him, which was invaluable, just to have them there with their eyes on the bed sores every day, because they change. And anyone who's had ALS or associated with it, you realize the symptoms are like different every day. You just kind of adjust your life to one symptom, and then another one shows up, and then you have to do that. So every day is like a new normal you have to figure out. So with hospice there every day, it was you had a team of people to help you make those decisions and to make sure his care was what he needed. That was good.
We had home care on a regular basis. We had home care coming in outside of palliative. What palliative did for us was bring management of the medications and coordination of those issues that were constantly being kind of batted back and forth. So they brought coordination to us. And like I said earlier, I wish we had done both sooner, because that coordination alone was really valuable.
Thank you.
I seen the question about the bed sores. With hospice, my husband was a veteran too, and so we kind of had the value of both areas. And so he got a lot of his medicines from the VA, but hospice, the VA will give you the medicine, but they don't have the eyes to see every day what's going on there. And when you're dealing with bed sores, they can get bad quickly. And so he had to be, basically the treatment was the medication, the topical medications, which were really good that hospice provided. And then he had pain management, and he had to be rotated about every 20 minutes because of the bed sores.
I think that's correct. So with hospice, with skin breakdown or sores, it's the hospice nurse who is going into the home as frequently as daily. And it'd be interesting also to hear your experiences with the 24-hour care. So one of the things with hospice is if something comes up at 2 a.m., 3 a.m., you call, you talk to someone immediately. If you cannot solve, or if there's any question, any doubt, any concern, the issue over the phone, that person, she or he, nurse, will come to your house 24 hours a day. So hospice is available 24/7 to have a person addressing those issues. The palliative service, the way I address that on palliative care, on the palliative medicine service, is I will involve a home health company, such as any of them. In this area, we have several. Generations is a large one, Centera is a large one, Riverside's a large one. There are many home health agencies, and they have nurses who specialize in wound care that will come out to your home as well. So palliative care really is an office-based specialty. I actually run a home-based palliative care company. So I go to individual homes and see people where they are. I meet them in their homes. That's unique to a lot of palliative medicine physicians, though.
Yep.
Hospice does go in-home as well as facilities, though, correct?
Correct. Yep. When I hear the word home, I think everyone's home looks different to them, and some people live in a house and some people live in a facility and everything in between. So hospice really meets you where you are. With my palliative medicine service, I do visits in patient homes, and we are moving into some of the local assisted facilities, but a lot of the local nursing facilities, the skilled nursing facilities, will not let another outside provider come into their facility.
Thank you, Jerry. You actually answered a question that one of the patients had asked us, and I'll just reiterate it one more time. They're asking, when I'm no longer independent, I will need to go to an assisted living or a skilled care facility. Will palliative care service be available to me at that time, or is it only available for in-home care?
Yeah, it's changing every day. So we are working with more and more assisted living and long-term care facilities on a daily basis. So we do go into a handful of facilities locally. I do think that's rare in that a lot of facilities staff their own PAs, nurse practitioners, and physician groups. Those medical groups really handle everything and often do not like to involve outside physicians. So it can be a little bit tricky, but it's dependent upon the facility. And prior to going into a facility, I would, like AJ mentioned earlier, I would interview them and add that to your list of questions, because you want to make sure that when you go into a facility, you're getting as many things as you want.
Thank you. And another one in regards to medications. Does palliative care cover for medications needed and basic equipment like gloves, gauze pads? An additional question is, if I am discharged from hospice, can I go back into palliative care?
Okay, so palliative care being a medical specialty, think of it like going to your doctor's office, except I would come to you. So for all of those medications, I write prescriptions if needed. For all of the equipment, I write prescriptions. I write prescriptions for wheelchairs and hospital beds and all of this stuff on a weekly basis. The ALS clinic, though, is going to be the best place to get the true medical specialty for ALS needs, in that they have the experts working with them. So when we run into situations where something is needed, I coordinate that with the ALS clinic or the neurology clinic to make sure the needs are being met. And usually that's talking to that clinic, getting the right kind of adaptive equipment or whatever is needed. And what was the second? Oh, can you go back to palliative? So yes, you can. So it's a sort of a continuum, and there's a big spectrum of changes that can happen. So if we start with palliative medicine, our body may progress to get so weak that we would say, you really would benefit most from hospice. It's actually not uncommon for people to come on hospice and their body stabilizes because they're having that daily or weekly nurse visit. They're having the aid, they're having that extra support. So we have people who come off of hospice routinely and go back to palliative medicine. So that is very common and completely acceptable.
Thank you. AJ, no pressure, but I know you mentioned earlier you had a checklist when you were interviewing for hospice companies. We have someone on one of our attendees who's asking, what are some good questions to ask when looking for a palliative care company?
I saw that question. It was running through my brain, some of the things. So I definitely ask, do you deliver medications to the home? They're going to cover the medications, but do they deliver, or do I still have to go to the pharmacy to get it? How large is your staff? If I have a particular CNA who comes every day, if they're not available, how many people do you have to back up? smaller companies, one of the things you might have to be careful of is they're going to be smaller. So it might not be as easy to get someone to fill in if somebody's on vacation or calls in sick that morning. You may not be able to get somebody to fill in, and or it may not be at the same time. So, just ask, what size is your staff? How do you deal with people on vacation? How do you deal with people calling in sick? The 24-hour is another good one to ask about. I talked to one smaller hospice company that was on the other side of the water. I'm in the Tidewater area. That was on the other side of the water, like 45 minutes from me. And so if they have only 2 nurses and only one of them's on call and it's going to take them 45 minutes to get to me, I might want to think about getting a hospice company a little bit closer to me that might have staff a little bit closer. They can get here quicker, because if I'm in a panic, I want somebody as soon as I can. Exactly what services are they going to provide for that 100% coverage from Medicare? In other words, am I going to be limited to 1 hour a day from a CNA? Most of the larger companies are going to say yes, because they're for profit and they have certain quotas they need to meet. A nonprofit might have a little more flexibility there. They might say to you, we'll give you 1.5 hours, or we're going to give you what you need. And then you can kind of negotiate. So if that's going to be important to you, knowing what their flexibility is on that. Those are the ones kind of off the top of my head. I was thinking I probably should go back and try to find my list and see how relevant those questions still are today. And that's something I can try to get to NITU if that's beneficial to folks.
What I would say is, I'm going to add a couple things to that, if it's okay. I agree 100% with all of those. I think that's for the hospice, which you were clear about.
Yes.
So I agree. The other issue that I have had, I was an internal medicine physician prior to doing fellowship. There are hospice companies out there who tell you that they are going to stop every medication and only give you quote unquote comfort medications. If you hear that, I really think that's a red flag. Hospice should not stop all of your medications. You are on medications that are making you feel better and that are making you live longer. So I have gone to war with some groups in the past when I worked in a hospital setting over being told, oh, they're going to come on service and we're going to stop everything and just give them these 4 scary medications if they need them. Well, that's not okay. So that would be one I would add. When you're looking at a palliative medicine service, one of the things that I really strongly advocate for is asking them what they mean by that. Asking them if they have a fellowship trained, board certified palliative medicine physician on staff. There is a big difference in getting your neurology ALS care from a neurologist than there is getting it from me. I'm not a neurologist. So I would not advocate for you to come to me to manage your neurological condition. We need a neurology specialist. Much the same way, when you have those palliative medicine needs, you really, I would advocate strongly for getting a palliative medicine trained person. It's a formal fellowship, has been since about 2006. There are still many, many services out there who say we offer palliative medicine, and they don't have a palliative medicine trained individual on staff. The way you can go about finding palliative medicine, I will send that to you in just a minute. I want to pull up a website. It's word of mouth a lot of times, and then Googling. The problem is when you Google palliative medicine, you're going to bring up a lot of hospice agencies because of the misunderstandings surrounding the terminology. But there is a website, and if I can't find it right away, I will send that in later and we can share it with you on how to find a local palliative care provider. I know there are some in Northern Virginia.
I will say, we actually did fire the first palliative care company we worked with because they didn't follow through. So when I was looking for the next one, we actually ended up at the one at Mary Washington Hospital. And one of my first questions was some of what you were talking about, who would they refer to if they needed to? And my second question was, what happens when we move between the two? And the answer I liked was, you will keep the same nurse practitioner as your primary care person who is palliatively trained, even though she also did hospice. So it was a much seamless, for us, a seamless transition that assured me I would still have contact with the same folks and I wasn't having to learn a new group of people. And I assume that's how you're probably set up too.
It is continuity. Absolutely. I think continuity is the most important. I really enjoy it because my own service, I meet people on palliative medicine, and then at some point in the future, some of them transition to hospice. It's wonderful to walk into a home, a facility, and see a family, a person that knows me and that I know. I think it provides better care anytime. All of you have alluded to that too. I think that continuity is really where hospice and where palliative medicine shines. They know you, you know them, you know their quirks, they know your quirks, and it's a team. They really become part of you and you become part of them.
That is important because, you know, when you have someone that's terminally ill, you have a lot of people in and out of your house constantly. Because my husband was a veteran, we had the VA people coming and going and the hospice people. And so you want to see that same face and get to know that person to where you feel comfortable having them in your home on a daily basis. And that is important. That continuity is very important. And I was going to say too, you know, the little things, just like being able to call that nurse 24/7. In the year that my husband was in hospice care, I think I maybe called the nurse once that I remember. So it's not like you need to do it often, but it's just good it's comforting to know that you can call somebody and somebody's right there and will come as soon as you need them. And the other thing I was going to mention too is that if you get with a hospice company that will deliver the medicines to your home, that was a big help to me too.
Yeah, and the medication delivery is huge. The medication delivery is a huge help because after hours, it's, you know, caregivers, whether you're formal or an informal caregiver, whether you're a family or you're simply a person who is trained to provide care of whatever need or whatever degree, it is a lot of stress mentally, physically, socially. The last thing you need when you're on a hospice company is to be running to and from the pharmacy and taking valuable time away from that which you should be spending with your loved one.
Thank you so much, Dr. McQueen, Vicki, Timmy, Sally, AJ. These are all the questions we received for today. This was very informative for our families. We saw a lot of questions, personalized questions come in. So I really want to thank you from everyone. And I want to also thank our attendees for attending this webinar, but also we will be having our next one next Wednesday, same time, 1 o'clock. And we will be focusing specifically on caregiving and, for ALS patients and also what the experience is like for caregivers. In the meantime, if you guys have any questions, any concerns, you're more than welcome to send me an email. And I look forward to seeing you guys next week, Wednesday.
Thanks.
Thanks, everybody.
Bye-bye.
Bye-bye.